Everybody have a nice weekend? How many of you would vote for a 4-day work week and a 3-day weekend every week? Come on, let's be honest. I mean, I would raise both hands on that one. Okay. That's effectively what we just had, right? All right. You guys ready for a couple of warm-up jokes? What did one eye say to the other? I see you. They're like, right? Just between you and me, something smells. Where do cats wait to pay their bills? Where do cats wait to pay their bills? Anyone? In the feline. Okay. I actually need this mic for this joke. I was actually pretty proud. This was my youngest daughter. This was a few years back. And she came up with this one all on her own. I remember the day she came up on it. She was super proud. What is Darth Vader's favorite dessert? I do it all right? All right. All right. That was for you, Reese. Okay. All right, you're starting to get into them. So, first post-quiz is due this Friday. You're going to find them more challenging than the pre-quizzes. Same format, but the whole concept is you've had a little bit more time with the material. You've had a lecture, and so recall should be relatively more quick. Still open book, open notes. There's no reason to wait. It's due 11:59 on Friday evening, so you don't have to wait that late, but just giving you as plenty time as possible. What I typically hear is, of the 5 questions that randomly I get, and the reason for that is you're sitting next to your friend, you might get some same questions, you might get different questions, and you might have them in different order. And it's only 30 minutes, so the whole idea is you're really not doing yourself any favor if you're not taking it by yourself, because it's supposed to give you a sense of how well you know the material. And the other concept here is we're in information age, and so the quizzes are kind of structured for the information age. What I mean by that is I know the answer is out there, and I know you can find it. The question is, can you weed through all of the garbage before you find information that's quality information? And that's kind of the age that we're in. So you might be able to Google something, but then you're going to have to gut check, this bozo doesn't look like this is a legit website. Maybe they don't know what they're talking about. Maybe I should check this with my notes. I remember reading about this somewhere in the text, okay? So the idea is you have a plethora of information at your fingertips. How do you sort through what's good information and what's bad information? And that's your professional future, is there's going to be a lot of information that's thrown at you. There's nothing wrong with Googling something. Just be mindful of the source, okay? If it's a chat room for GM trucks and they're talking about pathology, you might be in the wrong forum, okay? I'm just saying. All right. So any questions about pre or post quizzes? All right, we dropped the lowest pre and we dropped the lowest post. So if that long weekend wreaked havoc on you and you need to use your freebie, that's there for you. But you only get the one, okay? And no, you can't borrow a post-quiz lowest score and use it on 2 pre-quiz lowest scores. It doesn't work that way. Okay, we went over this first day of class, so I'm just kind of reinforcing what we already talked about. Okay, enough of that. Any other questions before we get going? We got to finish out cell injury. How many of you actually looked forward and looked at apoptosis versus necrosis? Okay, great. So this is going to be a little bit of a review for you, but hopefully it'll really make sense. And that's the whole point, is if you spend a little energy taking a peek, and it doesn't take much time to do this, and you looked at kind of the differences, a lot of what we're going to compare and contrast today will make a lot of sense. It'll sink in. We're going to reinforce what you already know. So on this slide, what we've got is we've got reversible versus irreversible injury. And so what we're trying to highlight is this concept that every day we're battling injury stimuli. And if we go back one list to where we left off last week, we talked about not a comprehensive list, but a fairly detailed list of many different things that can cause cell injury, whether it's oxygen levels being too little or too high, whether it's different types of chemicals like hydrochloric acid, where we saw in Barrett esophagus, different types of infectious agents or immunological reactions. We'll look at different types of imbalances like nutritional imbalances. We'll look at trauma. We'll look at aging. So all of these things will take this normal cell and they'll move into this phase where they're stressed. The cell becomes stressed. And indicative of stress is two main things: cellular swelling and then what we call a fatty change. Cellular swelling is the cell takes on water. And in a damaged tissue or a damaged organ or a damaged cell, if there's a mass increase or weight gain of that particular tissue, organ, or cell, the contribution is primarily from water uptake or water infusion. And the cell literally starts to swell. It gets bigger. You've noticed this like in inflammatory situation, like with your skin. You get a cut, and what happens? Or you have trauma, you sprain your ankle, what does it do? It swells. Okay, you get a lot of water moving into the area. Now, there's an increase in blood flow, and that's why it gets red, and we're going to talk a little bit more about this in the next week, about the inflammatory response, but understanding that there is an infusion of fluid, primarily water. Then we get this blebbing that takes place, and we get a changeover of vacuoles that have a lot of fat in them. In this fatty change, and we highlighted this, this happens most evidently in cardiac tissue, myocardium, and liver tissue, or hepatic liver tissue, where these tissues are highly dependent upon lipolysis or fat metabolism for energy. And so you see this exaggerated like in liver tissue. So if a liver tissue becomes stressed, let's say there's a lot of toxins and the liver's in a compromised state, you'll see a lot of fat content in the liver. We call it fatty liver. One example, and we're going to talk about this in our liver section when we look at liver diseases, we'll talk about alcoholism and why does an alcoholic liver become fatty. This is the reason, is it's under toxic injury all the time. Now, you'll get some clumping of the DNA or of the chromatin, and you'll get membrane blebbing that will take place at some level. But for the most part, if the injury goes away, it'll return back to normal everyday life. This happens from UV radiation. This happens from the foods that you eat. This happens from stress levels from horrible professors, okay, who give unfair exams. Okay? We're designed to be able to handle some level of stress at the cellular level. Well, there's a point at where it becomes irreversible. And really, the trigger point here for the cell is when you lose the membrane. When the integrity of the membrane is compromised, now the cell is over. And you go into this necrotic state, typically. And you're going to have loss of organelles like the endoplasmic reticulum and the ribosomes will disintegrate. You'll get more fluid coming in because you've lost the membrane, so now it's totally going to swell. In some cases, it swells so much and then it ruptures because of all this fluid intake, and that compromises the integrity of the membrane. And without that membrane integrity, you don't have the ability for electrolyte balance, right? You've got your ions are completely off. Your sodium-potassium pumps are totally over. They can't establish an electrical gradient. So in this situation, you get a moth-eaten looking cell. Like the membrane, the structure around it is completely tattered. It looks like a sweater that's been eaten by moths. And we'll show you some pictures here in a second. This is necrosis, and that is not reversible, irreversible. Once that membrane is gone, irreversible. Well, there's another type of cellular death which is more organized, and we introduced it last week, and that's apoptosis. And we're going to talk about that in more detail. But before we get there, we're going to compare and contrast the two. Before we get there, I want to talk a little bit more about this cellular swelling. So in this cellular swelling, this is hematoxylin eosin-stained samples. These are samples of kidney tubules. And you've got functionally normal kidney tubules on the lower left. And you can appreciate that these are cuboidal in nature. And the lumen of the tubule is the white space. And you can see the purple nuclei that are nicely circumscribing the kidney tubule. As we move from left to right, you can see less organization. Hopefully you can appreciate that. In panel B, which is the middle picture, you're starting to see that the membrane is starting to lose its integrity, and we're losing the architecture that you can appreciate on the lower left. If you move over to the far right, you can see that the architecture is very much compromised. Nuclei are gone, so we've lost our nuclear material. And these kidney tubules are in a necrosis situation, irreversible. Here, you might have some areas of reversible injury where you can see nice in a row 3. It's actually easier to appreciate the cuboidal epithelium in this picture right here. You guys see this right here? This is a nice little box. These are nice 3 cuboidal epithelial cells in a row. It's even easier than here. So you can kind of appreciate that this could reverse back to normal architecture, but here it's over. Okay? This is going to scar, and it'll never recover. So in cellular swelling, the first thing that we get is we get this hydropic change. This hydropic change is the uptake of fluid. That's what we've been talking about. We get vacuolar change, where the cells take on this vacuole phenotype, where they have these storage facilities of vacuoles, and in many cases they store fat in there. When it's an organ, the organ itself may become more pale in color if you were to examine it via autopsy, because it's swollen full of fluid. So in autopsy, it's very common for the medical examiner to weigh the organ, get an organ weight, and to evaluate the color or the consistency of the organ tissue itself. So fluid, like I said, water primarily, is responsible for this increase in weight in these organs that have necrosis or cellular damage. There's an increase in turgor pressure, and you probably remember this terminology from plant biology, where the turgor pressure is the fluid pressure that's pushing and keeping the cell open. And so if you have an increase in turgor pressure, then you can understand, or you can probably understand how those organelles are going to be under increased pressure. It's kind of like when you have plugged sinuses, or when you travel up from Phoenix and the pressure changes and your ears haven't popped and it's very uncomfortable. So the cell itself, with an increase in pressure, those organelles are going to feel that pressure. And that's what actually ruins the organelles, like the ribosomes, and starts clumping the DNA. Fatty change. This is, not surprisingly, liver. Normal liver in the upper right picture. Hematoxylin and eosin stain. You're going to see this all semester long. We call that H&E staining. Again, the dark purple dots are the cellular nuclei, and the pink tissue is the extracellular matrix. And then here, this is an area of infarct. Can you guys appreciate what I'm tracing right here on the screen? So this section right here is an area of a liver infarct, or necrotic liver. It's scarred. It looks organizationally very different than this. You guys agree? This will never come back to be functional liver tissue. This will always be a scar. It's very similar to like an old injury that you've had, like if you fell off a skateboard, or maybe you're just clumsy and you trip going to the bathroom. Okay, you got a paper cut. maybe it's like metal paper or something. And there's a monster gash, and then it heals, and there's a scar that forms. You can always see that scar. That's because the new tissue that moves in lays down new extracellular matrix, and that new extracellular matrix is organized differently than when it was designed embryonically. And so that creates a different architecture, which we call a scar. This is necrotic tissue. That's another name for it as well. Is cells have died, and now you have cellular necrosis, and you filled in the gap with like putty, okay? It's like when you move out of your apartment and they say, well, fill in all of the nail holes, and you had like a 8-foot by 10-foot picture on the wall. Well, those are some big nail holes, right? And so you puttied over the holes, and the holes are this big, and you can see them from here, right? Yeah, it's covered, and there's stuff in there, but it doesn't resemble the drywall that was originally manufactured. That's exactly what happens when we have scar. A scar is where necrotic tissue was replaced, or dead tissue was replaced with a healing or a wound healing process. Wait 1 second on that question, and we'll get to you. The other thing I want you to notice is, what's all this? Just go out on a limb. What do you think that is? Adipose tissue. That's what adipose tissue looks like histologically. Hopefully you remember that from probably 201 when you looked at different types of connective tissues. This is adipose tissue. And so this is a perfect example of how the liver is going to shift. And it's going to shift to preferentially favor vacuoles that have a high deposition of fat because it relies on fat metabolism. Question? Good? Okay. Bless you. I don't mind you guys asking questions. If I just need to get through a thought, I might have to pause you, and then we'll come back. So if you need to write it down, I'm older than you, so I forget faster. Okay? So you guys have to remember what your questions are. In the back. Why is it specifically fat? So it's a great question. The fat storing is the cell's defense mechanism to say, something's wrong, and I need to make sure that I have energy in case I'm not getting supplied with nutrition. And so by storing fat, now the cell can rely on lipolysis to generate ATP. So it's a defense mechanism by the cell, and you know that the cell is sensing that something is wrong and responding to it. It's just like, ecologists will study squirrel behavior in the fall, and they'll try to make predictions about the size of the winter, right? And so if the squirrels are putting away more acorns, then a lot of times they'll conclude, wow, a big winter must be coming. They sense that something's happening. So the cell does the same type of thing. It's a great question. Next one, apoptosis. So we talked about apoptosis. We talked about how it helps to digitate your hands and your feet, right? There's programmed cell death. So this is an organized process where the cells actually shrink in size instead of swell. And the reason that they shrink is because they go through a programming where they start to compartmentalize important stuff. They pack up maybe ribosomes, they pack up proteins, they might pack up different organelles within the cell that could be recycled. They'll pack up cytoskeletal elements, and they bud it out like in escape pods, kind of like in a sci-fi movie. And these escape pods are called apoptotic bodies, and they literally leave the cell. Completely different process. And because these apoptotic bodies are intact with a membrane all around them, they can be phagocytosed by a nearby cell, engulfed, fuse with another cell, and their contents can be incorporated into a recipient cell. They become a donor, and they donate their parts. Kind of cool. So apoptosis is what we call programmed cell death. The membrane always stays intact. In apoptotic mechanisms, you're never going to see a necrotic result. You're never going to see, that's another word for dead tissue, is necrosis. And we're going to look at all sorts of different types and flavors of dead tissue. Yeah, it sounds disgusting when you say it that way. Yes?
Does the cell
So the question is, how does the cell know to do this? So there are apoptotic signals that are sent within the cell intracellularly to signal the nucleus to say, okay, it's time to schedule apoptosis. In a traumatic event, like in a car accident, there's not enough time, so you just get necrosis. Okay. In trauma, you don't ever really have apoptosis. Okay. Usually, apoptosis is a developmental thing. So during development, like when you're making your hands. When we talk about the immune system and we're trying to educate the immune system, we will signal certain lymphocytes and we'll program them to die. We'll program them for cell suicide and we'll recycle their parts. And the reason we program them to expire or to apoptotically go away is we know that they're self-reactive. Like they're going to go find some part of our body and try to kill it. And so we intervene. Does that make sense? Yep. Yeah, this has nothing to do with apoptosis. This is very disorganized, and it would leave a coagulative necrotic scar in the kidney. So these nuclei are dying because of a necrotic injury, not because of packing them up and sending them off. Okay. Let's compare and contrast the two. So newsflash, whenever a professor shows a slide like this that says compare and contrast, you can fully anticipate there'll be test questions or quiz questions on it, right? I mean, right? You guys know this by now. Okay, so fully anticipate questions about what's the difference between the two. And we've nicely spelled it out. So in necrosis, let's start on the far right. Necrosis, this affects groups of cells. Whereas, and we'll talk about it over here, there's a lot of inflammation associated with necrosis. So think about like the last time you had like a mountain bike wreck, okay? Or you tripped going down the stairs and there was an injury to the skin and it got red and inflamed and swelled up. And it wasn't just one little dot. It was like, you know, your whole knee, okay? So lots of swelling, you lose membrane integrity, the organelles swell, you get lysosomal leakage. Those are lysosomes inside the cell contain enzymes. So when they are compromised, they dump their enzymatic contents, and that starts degrading the cell. You get random degradation of the DNA. You just lose the nucleus. Lyse cells can be ingested by macrophages because macrophages, they clean up the mess. Now, let's look at the difference. Over here, you can actually signal a single cell for apoptosis. It doesn't have to be the entire tissue. It could be a single lymphocyte, a single T cell, a single B cell. Those are types of lymphocytes. And you can signal them to go away. You don't have to get rid of the entire spleen or say, you know, just blow up the lymph node. Make the armpit explode. Get rid of that. Get rid of the axillary lymph node. There's something going. They just trigger one at a time. It's very accurate, very precise. No inflammation. Cells shrink, not swell. You get blebbing, but the membrane maintains integrity because as it blebs, it pinches off and sends off the apoptotic body. Increased mitochondrial permeability. You get condensation of the chromatin, and the DNA does get fragmented, and then the apoptotic bodies can get ingested by neighboring cells. Okay, so now I want you guys to team up, and I want you to look at these two pictures. And knowing what you know now, I want you guys to tell me and defend it. So I'll call on one of you. Which is a picture of necrosis, and how do you know that? Why do you draw that conclusion that it's necrosis? Which one is it, and why? Okay. Need a brave volunteer. Don't just shout out like, oh, it's that one. Walk us through your rationale. Okay, so I got half volunteer in the back, and then I got a more. Okay, Max, I'm gonna give it to your colleague for this one, and then we'll come back to you on the next one. How's that? Yes. Say it louder. Sorry. Necrosis is B. Why? Okay. Okay, you're kind of like, I think I heard some right answers in there. I heard some stuff might be a little confusing. So I agree with you that it's B. So tell me again, if you had to pick one reason as to why, and I think you ended on it, but one reason as to why did you pick B, that it's necrosis? What about the membrane? It's compromised. Okay. You have membrane integrity that's been compromised. I agree. Would anybody like to add to that? That is a correct answer. Anybody, Max, you want to add to that? You messed up. Okay. 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 Oh. Yeah. Active participator and honest, right? He just said he was wrong, and he didn't have to admit that. I probably would have not said anything, to be honest. Good for you. Good for you. Okay. Anybody want to add to that? What's your name back there? Giovanni? Giovanni. Okay, so Giovanni goes with necrosis and says because of the membrane integrity. And I agree. There are other clues as well that we could point out. So what are some other reasons that this one is what then? Apoptosis. So why would that one be apoptosis? Where's the blebbing? Do you guys see this giant nose coming out at you? Yeah, that's a pre-apoptotic body leaving the screen, coming right at you. This is scanning electron microscopy. Okay, this is a 500x magnification of a cell. And so it's at the same view, same relative scale. And the reason for that is it's important for you to be able to see that this is moth-eaten, and this cell is actually swelling compared to this one. Once this leaves, this cell will actually get smaller. So it's shrinking. Anything else? Any other thoughts or input? So, I mean, a cell is going to be somewhere in the range of probably 20 to 60 microns, depending on what the cell is. A red blood cell is typically 7 to 8 microns, but it's anuclear. So a cell that's nucleated is going to be 3 times, at the minimum, that size. So you're probably looking at 20 to 60 microns in diameter. So these apoptotic bodies are going to be like 1 to 2 microns. So they're small in comparison to the size of the cell. But what you can't see is you can't see the backside of that cell. So you don't know if it's got a big old caboose or what. You don't know. Okay. Pretty clear now that we talked it through? So I can see how you'd look at those and you might get confused, but I agree with Giovanni. The most obvious is look at how this has holes in it. Okay, that's necrosis. Most obvious here is look at this budding pre-apoptotic body. Okay, so carrying on, necrosis is irreversible. Once you have a necrotic injury, there's no going back. And when we get into wound healing, we're gonna talk about wound healing results. So we can go through a regeneration response or we can go through a healing response. And most of us heal now as adults, meaning there's a scar, but the tissue itself doesn't return to normal function. Does that make sense? And because of that scar, it's disorganized. Let's say you hit your head, right, and there's a big old gash on your head. Well, you could pull your hair up, and maybe there's like a bald spot, like the hair didn't grow back because the hair follicles never came, because there's a loss of function. So with necrosis and scarring, you lose functionality. So here, we're looking at a tissue that, this is kidney tubules, and this is coagulative necrosis within the kidney. We're going to characterize that here in a second. So the nuclei disappear, so you can see that there's no purple dots. Here's a couple of purple dots here, but they're not in the right spot. They're supposed to be aligning the renal tubules. So anuclear. We've lost the integrity of the nucleus. The nucleus disappears. The tissue itself has this appearance of looking moth-eaten, right, because of that membrane integrity being compromised. Over time, often what's going to happen is the tissue itself is going to bring in repairing cells. Macrophages will come in and clean up the trauma. Tissue fibroblasts will come in and they'll lay down new matrix. And so the gap of where the dead tissue went away will be filled in, kind of like the puttying the wall, but you're putting stuff in there that is different than what it originally had, so you lose the functionality. So we're going to start now classifying different types of necrosis grossly. Yes?
Is this scarring always a result of necrosis, or will there ever be a time where like new cells replace that area?
So the question is it always the result? Is the result always scarring when you have necrosis? And the answer to that is no. Typically in biology, the answer is never, always, or never, right? It's usually, it depends. And so we're going to look at variations as we move on. Generally speaking, as adults, when I say as adults, like really past the age of about 10, most tissues in the body lose a lot of their regenerative potential, including the skin. Skin's a very regenerative tissue or organ, but post age 10, the way that it heals and remodels, you end up resulting in a scar. But if you remember, like, you know, if you fell off a skateboard when you were 5 or 6, and you know now you look at your knee, you're like, man, I can hardly find the scar. But you know, I cut myself on my exam last semester, and it won't ever heal. You know, because as we age, our tissues lose the ability to regenerate. You compare that to embryonic wound healing. So there are neurosurgeons that will go in utero and do spinal surgery on spina bifida embryos, and literally the baby will be born with no scar on the spine, like on the back. Like you can't even see where they went in, because the embryo has retained the regenerative capability of healing. And we as adults, and in your early years of childhood, you still have it, but you lose that at about the age of 10. Right around puberty. I think puberty kind of messes everything up. Okay. With respect to healing. This is a disclaimer, since my daughters may watch this someday. Okay. So the types of necrosis clinically are categorized based upon some observations. And so this is a spleen. And in this image, what I want you to view or walk away with is I want you to view this architecture of how the spleen is healing. So if you've got a vascular network that comes in, and it kind of does this branching pattern, it enters in here and it perfuses all of these tissues. Then if you cut off blood flow, let's say right here, you're going to lose perfusion to this entire region that's covered by the red area, and so it creates kind of a wedged pattern of damage. So in a splenic infarct, you can see that there's 2 different wedges. And this is a this is an older wound, infarct, and this is a newer one. And this one is older because you can tell that the connective tissue that's remodeled here has completely changed the architecture and the look of that tissue. Whereas this younger infarct is still in the process of remodeling. It'll eventually get more pale, but right now it still kind of resembles the native tissue at some level. So with coagulative necrosis, organs that have a vascular tree that perfuses the organ, if you get a blockage here, You get an infarct, which is a type of necrotic injury, and it looks like a wedge. And so the kidneys do this, the heart, the adrenal glands. The injury that you're seeing, a lot of it's a contribution of the proteins that are here become denatured because now it's hypoxic. The tissue is hypoxic. This coagulative necrosis is secondary to acute ischemia. So that's what goes in the blank. What does that mean? Well, that just is a fancy way of saying that acute ischemia can lead to coagulative necrosis. So secondary to acute ischemia, meaning acute ischemia would cause coagulative necrosis. What is acute ischemia? You lose blood flow immediately. The tissue becomes ischemic. Oxygenation levels drop. It becomes hypoxic. And then you get tissue damage. So if we're talking about heart tissue, you'd see the same thing, and we would call that a myocardial infarct. But the classification pathologically is a coagulative necrotic scar. So when they're talking about, oh, phew, Grandpa had a close call, you hear from your mom, like, Grandpa had a close call, but, the doctor called and said, it looks like we got to him in time, and there's no scarring of the heart. So I think we're going to put the stent in, and he should be okay. There's no scarring. What's he talking? This is what he's talking about. So when he says, unfortunately, we're going to do the stenting, but the tissue has been starved of oxygen for a long time, or the heart's been ischemic, it's an ischemic episode, we didn't get there fast enough, I'm worried about the extent of the scar. What the doctor means is he's worried about, or she's worried about how big the scar is in the heart and how much function of the myocardium it's going to compromise. Okay? So fibrosis is another term that we use to talk about scar tissue. Fibrosis is another term that we use to talk about scar tissue. So this is a wedge-shaped infarct. This is coagulative necrosis. This is scar tissue. This is non-functional healed tissue. This is also fibrosis. All of that is talking about the same thing. Okay? You guys with me? I know it's a lot, but we're talking about all the same thing. That won't be found in your textbook. That's like 4 different textbooks all into one. We talk about these kinds of lesions in so many different ways in the field. And so, what we're going to try to do, I want to try to teach you kind of the traditional classic language, which is coagulative necrosis. But then if you go on clinically, you're going to hear about scarring. You're going to hear about fibrosis. You're going to hear about infarcts. So I'm kind of weaving in a lot of the street lingo into kind of the traditional textbook language. But classically, this is called coagulative necrosis. Okay? All right, next one. Oh, wait, no, sorry. Coagulative necrosis. Let's use a couple of examples. So here is an image of a normal, infarcted kidney. Not normal at all. Infarcted kidney. And what might be difficult to appreciate is, where is the scarring, Dr. Keller? Well, here is a normal kidney. So let's look at them side by side. Hematoxylin eosin, so H&E staining. We've got normal on the left, infarct on the right. And these little round spheres or tufts are the glomeruli. Right, that's the functional unit within our kidney tissue. And here, they're more pronounced because they're dark. They're dark because they have a ton of these in them, or probably these, actually. They're young infarcts. And they look dark, and they're scarred or fibrotic. And if you blew out and looked at it grossly, not microscopically, you would see a wedge in the kidney on autopsy. Okay? All right, coagulative necrosis. Liquefactive necrosis. Liquefactive necrosis is kind of gross, to be honest. It tends to target neurons and glial cells of the brain because of the high content of hydrolytic enzymes that are present there. You get a lot of degradation of the tissue when the tissue becomes compromised. So if you reduce blood flow to the brain tissue, like there's a stroke, okay? Patient has a stroke, blood flow is cut off to the brain. The parenchymal tissue of the brain, that just means functional tissue of the brain. Then you release a bunch of enzymes. They start degrading the neural tissue, and it leaves kind of a pussy mess or a liquid-like tissue. That's where it gets its name, liquefaction. In some cases, you get a lot of pus that appears to be what we would see in a pyogenic infection. So liquefaction necrosis, you would know it's liquefaction because of the target tissue. So you're going to see this in neural tissue. If we look at caseous necrosis, actually we're getting more and more disgusting as time goes on. Coagulative is probably rated G, and then it gets worse from there. Caseous necrosis is a combo really between coagulative and liquefaction. So that's what goes in the blank. And caseous necrosis kind of has an appearance like cheese in tissue on a gross level. And I mean macroscopic. Okay. Examples would be in a tuberculosis infection, where you can see in the top image, this is a tuberculosis-infected lung where you have an area of caseous necrosis. You've got this yellow and white cheesy debris right here. This nodule is caseous necrosis. These bottom images, this is caseous necrosis of a lymph node, a hilar lymph node. And similarly, so you can appreciate right here under radiograph or x-ray, on the right lung, we've got the lesion, and here's the lymph node that is caseous necrosis infected. So its tissue has died off, and it kind of has an awkward, cheesy-like appearance. Fat necrosis. Fat necrosis tends to target tissues that go through death or traumatic injury that have a lot of fat consistency, and that's why it's called fat necrosis. So breast, pancreatic tissue, other abdominal organs, these tissues have a high content of lipases, which break down fat. And these lipases that break down the fat, and what you're looking at in fat necrosis, are all these little white nodules. Okay, so this is tissue, this is fat tissue out of the abdomen, and you can see all the little nodules of fat necrosis. And so what's an interesting process to explain is the lipases that are released, they digest the fat, so they take the triglycerides and they make them into free fatty acids. So triglycerides to free fatty acids. These free fatty acids, they bind up with calcium, magnesium, and sodium that's in the extracellular environment. And that process leads to what we call saponification. And that's how you make soap. So these nodules of fat necrosis have a consistency of like ivory soap. So if you were to palpate this tissue on the benchtop, you would feel like little pebbles in the fat tissue. And they'd have a consistency of like ivory bar soap. You guys with me? So the lipases break down the triglycerides into free fatty acids. Those free fatty acids now bind up with calcium, magnesium, and sodium that are found in the extracellular environment, and it creates soap, or it saponifies the fat. Did I answer your question, Max? Those are the pebbles. These little white pebbles, yep.
So it's the same consistency, but it's like basically making your fat into little soap particles?
Yeah. Yeah, so interesting scenario. Fat necrosis is one of the most common misdiagnoses of breast cancer. And so, remember, if we go back a few slides to the list of things that cause cell injury, and aging was on the bottom of the list. So as we get older, our tissues age. And so in women, as they age, their tissues age. And so breast tissue will saponify in women, and some women are more susceptible to fat saponification in their breast tissue. And so under self-exam, they might feel a lump. and it's legitimately there. They go in to see their doctor, okay, and that saponified lesion may light up on a mammogram. Then they go in and they do a biopsy and they pull it out and they say, it's negative. Phew, it's not breast cancer. And then the woman's wondering, like, well, what the heck is this? Because I feel like I got other ones. And then the woman, is told, well, that's just your native breast tissue. You have some natural lumps in your breast tissue. This is what they're feeling. So if we explained it to them in this way, it might be a little bit easier for older women that are getting mammograms, that are worried about breast cancer because it runs in their family, to understand what the false alarm was all about. That make sense? Yeah. Okay. Again, now we're going like rated R. Gangrenous. Ugh. So gangrenous necrosis is really more of a clinical term. Okay, it's not traditionally or classically a pathological category of necrosis, but it's become so commonplace that we've kind of adopted it now in the vernacular being a clinical term. So we've got a couple of different examples. We've got dry versus wet versus gas. And it really depends on where it happens. Okay, so for example, then I'll get to your question. With gangrenous necrosis, this is typically caused by the death of tissue due to hypoxic injury, so blood flow is reduced. So if somebody's exposed to the elements, they're out in cold weather, and they're not prepared, a lot of times they'll get gangrenous necrosis of their extremities, and this is what you're seeing right here. Death of tissue due to blood flow reduction. Lower legs are common. Bacteria often invades the hypoxic tissue immediately. You'll see this not just in cases of exposure, like extreme cold temperatures. You'll see these in patients that, for example, have perfusion problems of the lower distal extremities, like unmanaged diabetics, or patients that have diabetic foot ulcers on the lower distal extremities. They get these types of lesions, this becomes infected, and then unfortunately they have to amputate. So this is an example of dry gangrene. But it's really a result of coagulative necrosis. So technically it's a coagulative necrosis category. You guys understand? But we call it dry gangrene. Wet gangrene typically happens when you're talking about internal organs. And so it's in a moist environment versus a dry environment on the external extremities. So with wet gangrene, usually it's swollen, cold, black in color, and there's a foul odor or a pus. You don't typically get pus here because usually it's dry. Okay, unless the socks are wet and they've been walking on it, then they could take their socks off and it could smell. That actually does happen with some diabetic foot ulcers where the socks have been bleeding for a while, and so the wound on the foot is saturated, and they take the sock off, and it smells infected. Okay, so wet gangrene is usually internal organs, and then the last one I'll get to your question. Gas gangrene. Gangrene is usually a result of Clostridium infection, which is an anaerobic bacteria. That anaerobic bacteria releases a lot of toxins and hydrolytic enzymes, and then you get gas bubbles that form. So the gas gangrene is usually related to a Clostridium bacterial infection. Okay. Question?
So if you go back to the other slide, you said that like this is misdiagnosed as like breast cancer. So if you did have this instead of breast cancer, like what would you do about it? Like, isn't it still bad?
No? Okay, so the question is this oftentimes a misdiagnosis of breast cancer? And the answer is yes. Sometimes, patients will get screened. They'll do a physical exam, they get a mammogram, then they do a biopsy, and the histology comes back and says, oh, it's saponification, it's not cancerous. And so the diagnosis is good because they don't have breast cancer. Now, unfortunately, what the patient has is they're just getting older, and their fat tissue is starting to break down as time goes on. If you were to palpate their pancreas in that same woman, you'd probably have the same situation, okay? Because it's going to be ubiquitous in the body. All the fat is probably becoming a little bit more lumpy. So it's not really dangerous. It's just part of the aging process. But one could argue age is very dangerous. Yeah. There's really nothing you can do about this, to answer your question, no. Now, you would still monitor and watch it. You'd have a baseline on that particular patient if they're female. And breast cancer does happen in males. I mean, don't think that men cannot get breast cancer. It's far more rare, but it does happen. But you would have a baseline to say, okay, on physical exam, if you see something like this, it probably isn't cancerous, but let's do a mammogram, maybe more frequently just to screen. A biopsy would confirm it. You would know right away on biopsy. Mm-hmm. Yeah. Yeah. Yeah, they would. They may not explain it as fat necrosis. They might just say it's negative for cancer. It's more common that that's what they explain. No, because fat necrosis, let's say in a 67-year-old female, is quote-unquote normal. You wouldn't necessarily prescribe anything. There's nothing you can do about it. You wouldn't subject them to surgery. I mean, yeah, this is kind of a normal part of the aging process. Yeah. Could it happen in your liver? That's a good question. Yeah, it could. Typically what happens, though, in liver when it gets really fatty is it moves over into a cirrhotic situation where it moves from fatty to scarred. So it doesn't stay here. But you would have an intermediate phase in a patient that had steatotic liver, and we'll talk about this. But they usually transition if the toxin continues, and they'll move into scarring. Yeah. Gangrenous? Yep. That's okay. Yeah, it often does. So the question is, if a diabetic patient that's, let's characterize it, unmanaged diabetes, and not always, but oftentimes it's type 2, they have vascular disease of the distal extremities. And we'll cover this in great detail. And then blood flow is reduced, and so they get an infection on their foot. It goes gangrenous, and they get it amputated. And the question is, does it fix it, or does it continue? Oftentimes it continues. And so they'll just have to move more proximally with the amputation. So they might start at the toes, then they take off the foot, then they try to go below the knee, and that's where they try to stop, because you can get prosthetics fit for below the knee quite easily, because if this joint is intact, the prosthetics work much better. When you go above the knee, it's much more difficult for ambulation. And that's when you'll see patients more in wheelchairs when they're above the knee. Versus with below the knee amputees, a lot of times they can get a prosthetic fitted. How much what? Oh, it just depends. I mean, if this is an exposure injury, like let's say somebody's underprepared and they get caught, in very cold weather, and I mean, this could happen in a day. Yeah. In a diabetic patient, oftentimes it happens over weeks to months. Okay. All right, so let's look at histologically. And so, like you can see here, these are from the DVD in the bookstore, these images. But like I told you, I'm providing you with these images, and you can download these images. You don't have to buy the DVD, but if you want more of this kind of detail, let's look histologically, because skin gangrene that we just talked about, this is our gross observation. So let's be true to form. Let's talk about microscopically, this is skin. And we're talking about the foot, so I flipped it, right? Does that make sense? So this is the epidermis instead of up top because it's the foot. Plantar skin. This is the dermal tissue. This is normal dermis on the left, and you can appreciate the architecture. Normal dermis is cell poor and matrix rich. There's a lot of extracellular matrix, and there's fewer cells. So there's more pink and less purple. Down here, there's more purple because it's cellular rich, And there's less pink because it's matrix poor, relatively speaking, to the dermis. So let's compare the dermis of a gangrenous biopsy. Look at how many cells are here. Look at how purple that stain is. All of these purple dots are inflammatory neutrophils that have infiltrated. Inflammatory neutrophils. They're the first cells that show up in inflammation. They're the first responders. And we'll talk more about that. But do you see the big difference? This is a higher magnification view of a region that would be right here. So this is what you're comparing. So that's the dramatic difference. Okay. Let's move into this part of the lecture. We're going to talk about some of the mechanisms. And these mechanisms of injury look scary at first, but they're not that bad. So we're going to walk through these slowly. And you can see up top there's the injurious stimulus. And let's look at the different categories of problems when we get an injury. Now, keep in mind, back it up to that list of injuries that we see every day. UV radiation is an injury, right? So you're exposed to injury all the time because you go out in the sun. And you have ways to combat it. But if there's an injurious stimulus here that can down-regulate ATP, cause membrane damage, cause damage to the cytoskeleton, or trauma to the DNA, you can see all the downstream events that are problematic. So when ATP is compromised, right, we lead to cell necrosis because the cell has no energy to stay alive. When you damage the membrane, look, you cause trauma to the mitochondria indirectly. The membrane itself, you lose its integrity, so you lose the cellular components. And then now you put risk on the lysosome to dump its enzymes, and you start digesting stuff inside the cell. Cytoskeletal damage, membrane damage that takes place to the cytoskeleton. Ultimately, it's attached physically to the membrane, the cell membrane, and so you trigger the entire events all over again. And then over here, DNA damage, oftentimes, if the DNA becomes compromised, we will try to catch that. Our cells try to catch that. And as soon as they detect that the DNA is compromised, they do tend to signal, that's a signal for the cell to go through apoptosis. And so that does happen. You go to the beach for this long weekend, okay? You're going to have to go south because it's pretty cold most other places. But if you go to the beach over this long weekend, or spring break's coming up, right? All of you are like, not fast enough, Keller. Let's say you go south for spring break and you're going to get some rays. You're going to have a lot of DNA damage. I guarantee it. Doesn't matter how much sunblock you put on. The good news is your body is able to trigger the cells that have a lot of the DNA damage for apoptotic death. So it doesn't become a problem. Okay? All right, so the cellular response. Well, there's two main types of things that can happen. We've got autophagy. This is a cell that's split down the middle, and autophagic responses are on the left, and heterophagic responses are on the right. Autophagic means stuff that the cell is doing on its own. Heterophagic means stuff that's happening with an adjacent or a neighboring cell. So the cellular response is going to depend. It's going to depend on the injury. What kind of injury is it? How long did it last? I mean, did you fall asleep, in Cabo for 1 hour or 1 day? Depending upon how much rum you had, I guess. And it depends on the severity. Okay, the severity of the injury. So the autophagic responses, let's look at what the cell can do on its own. Well, you have a lysosome. It can actually fuse with a vacuole, and you call this a autophagic vacuole now. And then this can dump its contents as it digests the vacuole's contents. It dumps its contents via exocytosis, and those particles are eliminated. That's if this particular mitochondria was damaged. It can get rid of it, spit it out. Now, let's look at heterophagic responses, where another cell can be involved. Well, let's say you ingest a particle. Let's say you ingest one of these exocytosed particles from a neighboring cell. You put it in a vacuole, a phagocytic vacuole. You fuse it with your own lysozymes, and you digest it, and now you dump out a digested particle. So these cells that show up into damaged areas, or the cells that are in the damaged areas, both are playing a role in recycling or cleaning up the debris. That's kind of the take-home message here, okay? Is these cells that are present and then cells that are recruited in are going to participate in trying to clean up the trauma or the damage in that particular tissue. So let's look at hypoxia. Hypoxia. The causes of hypoxia most commonly involve ischemia. Low oxygen environment due to a restriction in blood flow. So ischemia, as it's defined, is a restriction in blood flow. So ischemia is saying when a tissue becomes ischemic, that means blood is not moving in. That's ischemia. Hypoxia is talking about oxygenation levels. So if it's hypoxic, oxygenation levels are low due to low blood flow, which is creating tissue ischemia. Does that make sense? So that's how those two words fit together. Ischemia is talking about blood flow being low. Hypoxia is talking about the resulting oxygenation levels in the tissues being low. So causes of hypoxia primarily are due to low blood flow or ischemia. Now there's a adaptation that takes place. The adaptation that can take place could be either chronic or it could be acute. If the adaptation is chronic, meaning the cell can adjust to lower blood flow chronically over time and not die, then you're going to get a decrease in metabolism. You're going to actually have a decrease in the number of organelles. The cell is going to be on, kind of like engine limp mode. It's not going to be able to do everything that it normally does. But it's not dead. It's compromised. That's if the cell can adapt in a chronic fashion. If it cannot adapt and you've got acute turnoff of blood flow, you usually trigger necrosis. And so that's the difference in, like, say, heart disease. You've got a blood vessel that's slowly narrowing over time, okay? 55, 65 years of eating potato chips and sitting on the couch and not doing exercise slowly narrows the diameter of that vessel, okay? And so there are some chronic adaptations that take place. Now, the problem is if you've got vascular disease and then you have blood that clots acutely, you could actually have immediate acute disruption of blood flow, which is going to cause coagulative necrosis and an infarct. You understand the difference? So acute infarcts are different than ischemic disease of the blood, or of the ischemic disease of the heart. So here's our classic example of kidney tubules. Normal kidney tubules upper right, and then we've got acute tubular necrosis due to hypoxic injury. Why do we keep showing the kidneys? Well, so the kidneys receive about a third of all blood flow straight off the aorta. So if you have a patient that is in shock, let's say that's a car accident, and let's say it's a motorcycle accident, and the patient survives, they're worried about the head, they're worried about the heart, and they're worried about the kidneys. So after the head and the heart are stabilized, they're going to, probably the next day they'll be like, okay, let's look at kidney function. And the reason for that is if you tear your aorta, or if you're exsanguinating a large blood volume, the amount of blood flow that the kidneys get is dramatically reduced. And so the ability for a necrotic event to take place in the kidney is very high. Now, you can go through a kidney transplant. It's not as big of a deal. You've got two of them. Bless you. Oftentimes one is okay and the other one's compromised. You only got one brain, you only have one heart, so they usually pay really close attention to those organs first. Okay? So that's why we keep showing kidneys. Is in traumatic injury and pathology, you see a lot of kidney trauma. So why does this happen? What's going on here? Again, another scary slide. I know these mechanistic slides look frightening, but they're really not that bad if you walk through them. And this slide is kind of cool in a nerdy sort of way because there's so much going on down here that you guys already know. Okay, I'm about to prove it to you. You've already taken classes on so much of this. Okay? So let's just follow the diagram and follow the arrows. You guys ready? So here we've got acute blockage of blood flow. That's why there's this brown section right here. You've got red blood and it's distally not perfusing, so you get a blockage. Well, in the cell at the distal tissue, whether it's kidney or whether it's heart, the mitochondria don't have oxygen. If they don't have oxygen, what happens to oxidative phosphorylation? It goes away, right? Do you guys remember oxidative phosphorylation, also known as aerobic respiration? You get more ATP out of that process than you do what? Than what? Aerobic versus anaerobic. Aerobic is oxidative phosphorylation. Anaerobic is considered glycolysis. Yes, very good. Gosh, you guys are smart. Okay, so oxidative phosphorylation versus glycolysis. Now remember, glycolysis, when you turn glycolysis one crank, it nets 2 ATP. When you turn oxidative phosphorylation one crank, it nets, depending upon how you're counting, 32 to 36. Oftentimes it's called 34 ATP. So it's 34 ATP versus 2. You guys remember this? Oxidative phosphorylation is slower, but it's more long-lasting. Glycolytic pathways are quick energy, but not very much. So if you lose oxygen as your final electron acceptor, you cannot run through oxidative phosphorylation. We agree on that? You lose ATP. We agree on that? Or significantly diminished. If you lose ATP, your sodium-potassium pump is compromised because it takes ATP to run. You guys remember that? If that pump fails, you get an influx of calcium, water, and sodium. Sodium floods in because it's not being pumped out. Water follows sodium. You remember that? So that's where the water influx comes in. I told you it swells. Nobody asked, where's the water come from? It comes from right there because you lost blood flow. So the pump fails. Calcium and sodium rush in. Your pumps aren't pumping them out. Now water follows. You lose a ton of potassium, and that's why the cell swells. Make sense? So you already knew all that over the last 2 years. You just didn't ever put it together in this context. Okay, next one. Oxidative phosphorylation, ATP, is compromised, so then we resort to other sources of energy. We're going to go down fighting. We're going to turn up anaerobic glycolysis to the best of our ability. Okay? Let's see what happens. We reduce our storage form of glycolysis, which is glycogen. The byproduct of glycolysis is lactic acid. So you have a lot more lactic acid in the tissue. That causes a lowering of pH, making it more acidic. That's what causes the DNA to clump. Okay? Last one. You lose ATP. You start detaching your ribosomes. You detach the ribosomes, you can't make new proteins. So you lose protein synthesis. And you denature any proteins that were being manufactured. So that's what all this says right here. Decreased mitochondrial activity lowers what levels? What is the penultimate thing on this slide? ATP. Okay? Adenosine triphosphate. So there are so many semesters of basic bio classes on this one slide, which is why I love this slide in kind of a nerdy way. But more importantly, I like it because hopefully it connected some dots. And you're like, well, now I kind of understand why this is a problem for the cell. And I also maybe understand why I had to take some of these other classes before we could get to this point. Because otherwise, I'd be super lost, Keller. And some of you might be saying, well, I still kind of am lost. And so I'm going to encourage you to go to SI this week. definitely before you take the post-quiz. We haven't finished this lecture. We'll finish it on Monday. You can look forward. There may be some questions on the post-quiz on the remaining slides. The remaining slides are kind of bringing in calcium as being a problem. Okay? And you'll see some examples of how calcium being a problem, because calcium influxes into the cell. And so I'm going to show you that calcium influx, the cell doesn't like a lot of calcium. Cells typically try to store it or get rid of it. Okay? So that's where we're going to pause for now. You guys have a nice weekend. Don't forget the post-quiz on Friday, and I'll see you all on Monday.